All right, let's jump right into this explainer. Welcome, first-year physiotherapy grad students. Today, we are unpacking a massive cornerstone of pain management, transcutaneous electrical nerve stimulation, or as we all know it, TENS. Now, patients sometimes think it's magic, but we know it's not. It is highly specific science. We're going to bridge that gap between complex neurophysiology and your future clinical practice, looking at exactly how a low-frequency, pulsed rectangular current applied through surface electrodes can literally alter the human nervous system. Here's the roadmap for today. 1. The anatomy of pain. 2. The famous pain gate control theory. 3. The 5 types of TENS. 4. Clinical application and methods. And 5. The dangers and contraindications. Section 1. The anatomy of pain, from nociceptors to the spinal cord. Okay, so to effectively treat pain, we first got to understand the messengers, right? Enter the nociceptors. These are free nerve endings found all over our body tissues that fire off whenever there's an intense physical, thermal, or chemical stimulus. Once they get triggered, they release a neuropeptide that shoots electrical impulses along afferent fibers straight toward the spinal cord. Now, we've got 2 main highways for these signals. On one side, you have the A delta fibers. Think of these as the express lane. They're large diameter, myelinated fibers, which means they are fast, conducting at a velocity of 5 to 30 meters per second. They mostly come from skin receptors and deliver that super fast, sharp pain. On the flip side, we have the C fibers. These are smaller, non-myelinated, and much, much slower, cruising at just 2 to 5 meters per second. They originate from both the skin and deeper tissues to deliver that slow, lingering, aching kind of pain. So let's trace that signal's journey up to the brain. Step 1. The primary afferent fibers hit the dorsal horn of the spinal cord. Step 2. Second-order neurons take the baton, crossing the midline of the spinal cord to travel up pathways, like the lateral spinal thalamic tract. Step 3. Almost 90% of those second-order afferents terminate in the thalamus. And finally, Step 4. Third-order neurons carry that painful stimulus straight up to the cerebral cortex, and boom, that is exactly when the patient actually perceives the pain. Section 2. Pain Gate Control Theory, Melzack and Wall's 1965 discovery. Now we're going to zoom in on the posterior horn of the spinal cord. Why? Because all afferent information has to pass through synapses right here, which means this is our golden opportunity to intervene. To master TENS, you've really got to meet the gatekeeper, the substantia gelatinosa, or SG for short. These are cells in the dorsal horn that have an inhibitory influence on transmission cells, or T cells. Think of the substantia gelatinosa as a big, burly bouncer at a club. The T cells are inside, just trying to send pain signals up to the brain. The SG bouncer stands right at the gate and ultimately makes the call on whether those pain signals get passed along or get shut down completely. So here's where TENS enters the chat. When we apply TENS, we're actually stimulating large-diameter, low-threshold A-beta mechanosensitive fibers. Because these guys are incredibly sensitive to electrical stimulation, they conduct impulses to the spinal cord way faster than those sluggish A-delta and C fibers. This fast arrival essentially hypes up the SG bouncer, causing it to ramp up its inhibition of the T cells. It literally closes the gate before the slower pain signals can even get through. We call this awesome mechanism presynaptic inhibition. But hey, the spinal cord isn't acting alone here. We've also got descending influences from higher up. Brain centers, specifically the periaqueductal gray matter in the midbrain and the raphe nucleus in the medulla, also exert a top-down inhibitory influence on those T cells. When a patient is in pain, the limbic system prompts these centers to release neurotransmitters like noradrenaline and 5-hydroxytryptamine right down at the dorsal horn. This further reduces pain transmission. And, as you're going to see in a second, certain types of TENS specifically target this exact descending pathway. Section 3. The 5 types of TENS, modulating the nervous system. All right, let's translate that cellular physiology into the actual dials you'll be turning on the machine in the clinic. Here are your primary options. First up, high or conventional TENS. You dial in a high frequency, we're talking 40 to 150 Hz, and a low intensity. This targets those A-beta fibers to work via that bouncer gate control mechanism we just talked about. Next is low or acupuncture-like TENS. Here, we completely flip it, a low frequency of 1 to 5 Hz, but a high intensity. This actually stimulates the A-delta fibers, sending a signal straight up to the midbrain to trigger that descending pain inhibition, which releases natural opiate-like substances like endorphins. And third, burst TENS.
This one uses a high frequency and high intensity in short little bursts, which effectively combines both conventional and acupuncture-like TENS to tackle pain from both angles at once.
I want you to burn this number into your brain. 30. 30 milliamps is your vital clinical threshold. When you're applying high TENS, you've got to keep the intensity strictly between 12 and 30 milliamps. The patient should feel a pleasant tingling, kind of a pins and needles sensation, but absolutely zero pain or muscle contraction. However, for low TENS, you've got to push that intensity to 30 milliamps or higher. It's going to produce a sharp, pricking sensation and an actual painful muscle twitch. But you know what? That strong stimulus is exactly what's required to force the midbrain to release those sweet internal opiates. Rounding out our 5 types, we have pulsed modulated TENS. This one is super customizable, letting you continually shift the frequency, pulse width, and intensity so the nervous system doesn't just get used to the signal and tune it out. And finally, brief intense TENS. This uses a 100 Hz frequency, a long pulse width of 0.2 milliseconds, and a really high intensity, well above 30 milliamps. Because it's so intense, you only ever leave this on for a maximum of 15 minutes.
Section 4. Clinical application and methods. Treating the patient.
Okay, clinic time. You've got a real patient sitting in front of you. Where do the pads actually go? Your choice of electrode placement needs to be highly strategic. You're basically mapping the patient's pain pathway. You've got 4 main go-to options. 1, you can slap the electrodes directly over the area of greatest pain intensity. 2, you can place them over a superficial nerve that sits proximal to the pain site. 3, apply them to the specific dermatome associated with the pain. Or 4, you can place them right over the nerve trunk trigger point. Your anatomy knowledge is what dictates the placement here. TENS is just incredibly versatile. You'll see it indicated for a huge variety of clinic conditions. We're talking chronic pain syndromes, reflex sympathetic dystrophy, obstetric pain, and postoperative pain, where we often just do a single 40-minute daily treatment. It is also phenomenal for phantom limb pain. In fact, patients dealing with phantom limb pain sometimes get incredible relief by continuously wearing a portable unit for 24 hours straight, or specifically running it at night just so they can finally get some sleep. Section 5. Dangers and contraindications. Safe clinical practice. Listen up, because as a grad student, you need to learn right now that knowing when to keep the machine off is just as crucial as knowing how to turn it on safely. Let's hit the absolute red flags. You must never, ever use TENS on patients with cardiac pacemakers because our electrical frequency can directly mess with the pacemaker's function. It is strictly forbidden during the first 3 months of pregnancy and in any hemorrhagic conditions. Do not place electrodes over open wounds, the eyes, the mouth, or the carotid sinus, no exceptions. And purely from a physiological standpoint, keep an eye out, because continuous long-term application of high TENS can sometimes cause an electrolytic skin reaction right beneath the pads. So, we've traced the whole path, right? From the nociceptors down in the tissue, up to the dorsal horn bouncer, and right into your hands as a physical therapist. Always remember, a TENS unit isn't just some magic box you plug in and ignore. It is a dynamic, active tool for modulating the human nervous system. As a future clinician, the ultimate question is this: will you use this knowledge to truly master the gait, or will you just blindly treat the symptom? The choice and the profound relief of your patients is entirely in your hands.